Hi, I'm Dan Resnicek from Pacific Northwest Urology, and today I'm going to be talking about bladder cancer. Bladder cancer is one of the top 5 cancer diagnoses every year in the United States. If you or someone you love has been recently diagnosed with bladder cancer, this video is for you. Today I'm going to be going over the basics of bladder cancer diagnosis, workup, and treatment options. I would like to also state that there are many other good references out there online for you to look up. I also recommend the National Comprehensive Cancer Network, or nccn.org. They have patient-centered guidelines that provide a very thorough and detailed outline of bladder cancer staging, treatment, and workup. I also recommend Bladder Cancer Advocacy Network, bcan.org. These are references I oftentimes give to my patients. So today, what are we going to cover? First, we're going to cover the basics of bladder cancer. What is bladder cancer? How does bladder cancer happen? What are the symptoms of bladder cancer? What is the workup of bladder cancer? And how is it treated? So first, what is bladder cancer? It's important to understand the anatomy of the urinary system to understand how bladder cancer occurs. Urine is first produced by the kidneys, which filter the body's blood and remove the waste products. After this filtering is complete and the urine is created, the rest of the urinary system is designed to transport and store and then excrete the urine. After urine goes into the kidneys, it is then transported to the bladder by 2 tubes, the ureters. Urine is then stored in the bladder until the appropriate time when it receives a signal to urinate. Urine is then transported out of the bladder through the urethra. The whole system beyond the kidney and the collecting system is a watertight structure, which is important because it helps separate the urine from the rest of the body. You don't want to be reabsorbing the waste products you just created. The watertight layer that holds in the urine is the lining of the urinary tract, which is known as the urothelium. The urothelium is a very special layer that's impermeable to both solutes or salts so that you don't reabsorb the waste products, and it also helps protect you against infections and bacteria. The layer is watertight despite the fact that the bladder stretches and compresses, whether it's filled or empty. The ureters, bladder, and urethra are all lined with the same urothelial substance on the most inner layer that separates the urine from the rest of the body. The vast majority of bladder cancers in this country come from the lining of the urothelium within the bladder. These are known as urothelial carcinoma. Historically, it was also called transitional carcinoma. There are some other more rare bladder cancers present. These are known as adenocarcinoma, squamous carcinoma, or small cell carcinoma, but these are very rare and the treatments and workup are very different from urothelial carcinoma. So I'm going to focus on this video only on urothelial carcinoma of the bladder, which is far and away the most common type. So next, it's important to go over, how does bladder cancer occur? Cancers occur when cells in your body start to grow and copy themselves uncontrollably and potentially invade and spread to other tissues within the body. Oftentimes, there is damage to the DNA in those cells, which controls how the cells grow and how they replicate. Damage may turn on a gene that promotes growth, or it may turn off a gene that's a break in that system. Either of these will cause the cells to proliferate or to make additional cells. Normally, as you age, the cells in your body have to regenerate. Sometimes cancers can happen randomly as the cells themselves make a copy of themselves and an error can happen in the DNA replication process. Some chemicals that are consumed can increase the chance of these errors being produced, and those are called carcinogens. The kidney then filters out the waste products of the body, and some of the waste products include carcinogens. These are then put into the urine and then stored, sometimes at higher concentrations than the rest of the body. The bladder then stores these, sometimes for prolonged periods, which then increases the exposure within the bladder to these carcinogens. These then increase your risk of bladder cancer. Smoking is far and away the most common risk factor associated with bladder cancer. Other known workplace exposures include aromatic amines, which are used in the dye industry, and other chemicals found in the production of rubber, textiles, and several other products. Carcinogens themselves don't guarantee that you develop bladder cancer, but prolonged exposures to them increases the risk, and the longer you're exposed to them, the higher your risk of bladder cancer. This is yet another great reason to stop smoking if you haven't already. So next, let's move on and talk about what are the symptoms of bladder cancer. Most people are diagnosed with bladder cancer after seeing blood in their urine, which is known as hematuria. Sometimes a patient's urine may look normal, but when it's sent off for tests at a doctor's office, blood is seen microscopically, and this is known as microscopic hematuria. Blood in the urine can be a persistent thing that starts and doesn't go away, and sometimes blood in the urine may happen only in one episode, goes away for weeks at a time, and then may come back at a later time. A single episode of gross hematuria is concerning and should be worked up with your physician. Usually, the blood in the urine is painless with bladder cancer at early stages. In some people, they can develop other irritative voiding symptoms, such as burning with urination, more frequent urination, urgency with urination, which means that you have a very sudden urge to urinate and can't hold it any longer. Other patients can develop a weak urinary stream or difficulty voiding. A lot of these symptoms can seem consistent with a urinary tract infection, and it's important to be examined to see if you do have a urinary tract infection. If no bacteria is present, this may warrant additional workup. These symptoms are far less common with bladder cancer, but can happen. If the bladder cancer is caught late and has spread to other areas of the body, patients may experience back pain, weight loss, tiredness, swelling, bone pain, and other symptoms. What is the workup for bladder cancer? Your doctor will get a medical history and physical exam. Next, if your doctor is concerned for bladder cancer, you should be referred to a urologist who is a physician who specializes in diseases of the urinary system. Other tests that may be performed in the workup for potential bladder cancer include urine tests with a culture, urine tests with cancer markers, or a microscopic exam of your urine. Imaging tests that may be performed as well, including a CT scan, ultrasound, or MRI. A cystoscopy, or camera evaluation of your bladder, should be performed if bladder cancer is suspected or possible. This is a procedure in which a urologist uses a small camera to pass up the urethra to examine the urethra and the bladder visually while you're awake. The procedure itself takes about 5 to 10 minutes, and if there are suspicious areas, a small biopsy may be taken at that time period. Next, let's go over how bladder cancer is treated. If there is a visual tumor present or a biopsy has demonstrated bladder cancer, the next step is a transurethral resection of the bladder, or TURBT. This is a procedure that's generally performed under a spinal or general anesthetic by a urologist in a surgery center or hospital setting. In this procedure, a resectoscope is used, which is a specialized camera that's able to resect pieces of the bladder and remove them and send them for pathological testing. In additional testing of the tumor itself, tissues are also taken of the muscle and surrounding areas of the bladder to ensure that cancer is not present. The goal is to remove the entire tumor within the bladder at the time of the procedure and to confirm the diagnosis of the tumor itself. Also, the goal is to determine how extensive the tumor has grown into the bladder. In addition to removing the tumor, the urologist will oftentimes also perform an exam under anesthesia to see if the tumor is palpable within the body. Sometimes after removal of the tumor, a urologist may recommend an intravesical treatment with a chemotherapeutic agent. This is placement of a chemotherapy within the bladder itself, usually by the use of a catheter. This is typically performed at the time of the procedure or within 6 hours following the procedure. Mitomycin C and gemcitabine are typically the most common chemotherapy treatments used, and these help prevent recurrence of the bladder cancer. Talk to your urologist about if intravesical treatment with chemotherapy is right for you. So next, what are the next steps in treatment of bladder cancer after a TURBT has been performed? After the cancer has been removed, the cancer is then staged by a pathologist who looks at the tumor on the microscope. Staging is then a rating for how far the tumor has grown and is important to determine the next steps in treatment of your bladder cancer. There are a lot of factors that go into staging, which we will cover next. Staging is most commonly performed using the TNM staging system developed by the American Joint Committee on Cancer. The TNM system combines 3 factors to determine the overall stage of your cancer. T defines how far the tumor has grown into the wall of the bladder. N describes if the cancer has spread to the lymph nodes, and M describes if metastases are present. So first, let's go over the T stage. T stage, or how far the tumor has grown into the wall of the bladder, starts with the lowest rating of TA and goes up to the most aggressive or farthest growth, T4 disease. A TA tumor is a tumor only within the innermost lining of the bladder or the urothelial layer. This has not grown into the connective tissue within the bladder itself. These tumors may grow quite large, but are not invasive. Next in the T stage is TIS. TIS refers to a flat cancer on the inside lining that is fast growing and aggressive. This is also known as carcinoma in situ. Unlike carcinoma in situ described in other areas or other cancers within the body, carcinoma in situ of the bladder is aggressive and does require treatment because it can progress to invasive bladder cancer quite quickly. Next on the T stage is T1. T1 tumors have grown into the connective tissue below the urothelial layer, but not yet into the muscle of the bladder. Next on the stage is T2 disease. T2 describes a tumor that has grown into the muscle of the bladder. T3 disease describes a tumor that has grown through the bladder muscle and into the fat layer surrounding the bladder itself. T4 disease is a tumor that has invaded the nearby structures of the bladder, which may include the pelvic sidewall, the vagina in women, the uterus, or in men, the prostate or seminal vesicle glands. The N part of the TNM system refers to lymph node involvement. The lymph nodes in your body act to help your body fight infections. The lymph nodes of your bladder drain into your pelvis. If there is no spread to the lymph nodes, it is known as N0 in the staging system. If it has spread to one lymph node within the pelvis, it's an N1 on the TNM system. N2 refers to spread to more than one lymph node. N3 disease refers to spread to lymph nodes of the upper pelvis or common iliac lymph nodes. M on the TNM stage refers to metastasis. MX would refer to if we are unsure if metastases are present. M0 means no metastases are visible. And M1 disease refers to there are metastases or the cancer has spread to other organs or distant lymph nodes in the body. In addition to staging, which is how far the cancer has grown, there's also grading. Grading refers to how aggressive the cancer is. This is determined by a pathologist who looks at the cells on the microscope. Grading is now broken down into either low or high grade disease. An older version of grading referred to cancers on a 1 to 3 number system. So that is a lot to understand and digest. Let's put these concepts together one more time. Staging for bladder cancer is typically done on a TNM stage. T refers to how far the tumor itself has grown into the wall of the bladder, N refers to if any lymph nodes are present, and M refers to if any metastases are present. These are then combined into staging groups. Grading refers to how aggressive or how fast-growing the cancer appears to look when the pathologist examines the cells on the microscope. Staging is very important because it then determines the next steps in treatment. Treatment varies considerably depending on where your stage of your cancer is located. In general, there are 3 important groups to go over when we talk about treatment algorithms for bladder cancer. The first stage are non-muscle invasive bladder cancers. So these are tumors confined within the bladder, so there's no lymph node involvement, no metastases, and the stage is low, below a T2 disease, so TA, TIS, and T1 disease. These collectively, again, are known as non-muscle invasive bladder cancer. Overall, 75% of bladder cancers are diagnosed at this stage. If your cancer is located in this stage, it has not yet reached a point where it can metastasize or spread to other areas of the body. Survival is very good for non-muscle invasive bladder cancer. Treatments for cancer at this stage are usually local treatments with removal of the cancer by the use of the resectoscope and treatments given locally within the bladder, such as chemotherapeutic agents or immunotherapy agents given via a catheter into the bladder. The treatment algorithm for non-muscle invasive bladder cancer is somewhat complex, and I'll cover that in a different video at a later date. The second important stage to understand for bladder cancer is muscle invasive stage, or T2 disease as defined in the TNM staging. Once the bladder cancer has reached this point, it has a very high chance of spreading to other organs within the body. If it hasn't spread to other organs yet, and the N is 0 or low, and there is no metastases, it is highly recommended to undergo treatment at this point. Studies have shown the rate of mortality at 2 years with untreated bladder cancer to reach 85%. Treatment options for this point include surgery, or chemoradiation therapy, or a combination of the above. Important factors that play a role into deciding what treatment is right for you include your overall health and your ability to undergo a major surgery to remove your bladder, known as a cystectomy. Other factors to consider are you healthy enough to undergo chemotherapy? And what is your overall kidney function? Last important consideration to understand is, are there any contraindications to radiation therapy? If you do get diagnosed with muscle-invasive bladder cancer, it is highly recommended you go to a center that deals with and treats muscle-invasive bladder cancer on a frequent basis. In addition to seeing a urologist who specializes in muscle-invasive bladder cancer, you should also meet with an oncologist or a doctor that prescribes and gives chemotherapy agents, and also consider a referral to a radiation oncologist or a doctor that gives radiation for the treatment of cancer. There are a lot of nuances to the treatment of muscle-invasive bladder cancer, but this is a general overview of the treatment options. The last important stage group to understand for bladder cancer is metastatic disease. About 4% of patients will be metastatic at the time of diagnosis. If cancer has become metastatic, it is uncurable. Treatment is focused on helping the patient live as normally as possible and as comfortably for as long as possible. Treatments for metastatic bladder cancer are rapidly changing, and there have been a number of new or novel chemotherapy drugs to come on the market in the last few years. That's all I have today for the basic overview of bladder cancer. Next, I'm going to try to do a video on the treatment algorithm for non-muscle invasive bladder cancer in the next few weeks. If you liked the video today, please click like down below or subscribe to our channel. Let us know if you have any additional questions in the comment section down below or suggestions for other videos in the future. Thanks again for watching. I'm Dan Resnichek with Pacific Northwest Urology.